So I'll start by thanking the organizers and our chairman for the invitation to come and speak. So I just need to find my lecture. Now we're ready. Nothing like a bit of problems to get you started. This is the first slide. I have nothing to disclose, no conflict of interest. And my topic is CPAP. CPAP instead of mechanical ventilation. And this is, on the left side is a picture of baby at the Karolinska in CPAP, and the other picture is a schematic picture of the place where I work, which is the Astrid Lindgren's Children's Hospital in Stockholm, which is part of the Karolinska University Hospital. This is my disposition, so I'll say a few words in the beginning about physiology, the preterm breathing physiology, just to get us started, and then say some things about why we should avoid mechanical ventilation, and then go on to CPAP. How does it work, equipment, patient selection, and the trends which I think are interesting, and finish off with some points about caregiving. So if we think about the lung and the physiology, I think it's important to think about the transpulmonary pressure, because the lung volume is regulated by the transpulmonary pressure, which is the difference between the pressure in the pleural space, which is usually negative, and the pressure within the airway. So if you increase the pressure within the airway, the lung volume increases, or if you increase the negative pressure, the same thing will happen. So that's a very important concept. And the compliance is basically the stiffness of the lung. It's the volume change related to a change in pressure. And the work of breathing is the integral of this, all of this happening. And this slide is a little bit complicated, but it's the static pressure volume curve of the rib cage. And what I want to point out is that at low lung volumes, which is basically where many of our preterm babies are, the only thing that's keeping the system open is the vector, the rib cage. And these babies have a very soft rib cage. Does anyone have a pointer? So this is at when, thank you, Nils. And this is a big disadvantage for the preterm baby, because they are generally working at relatively low lung volumes, and it's only the rib cage that will keep the system from collapsing. And the preterm baby has strategies. All of the breathing strategies that the preterm baby has are directed to control the absolute lung volume. So that's why they breathe really fast and create sort of an auto PEEP. They achieve an auto-end expiratory pressure. And they have active expiration when they are exhaling. It's sometimes called expiratory braking. And they have a constant tonic activity of the diaphragm and the intercostal muscles. And so how can we help the baby that has a low lung volume and want to avoid mechanical ventilation? And why do we want to avoid mechanical ventilation in these, especially in these tiny babies? This is a picture that is from Australia, and it's preterm rabbits. And on this scale here, you see lung volume in the panel A and the B, and these are breaths here. And what they do is that they intubate the rabbit in the beginning here and use no PEEP. And here they use PEEP and let the animal breathe spontaneously. And see what happens is that the lung volume increases successively breath by breath. And this is really important because if you're doing it like this and intubate the baby straight away, you basically risk damaging the lung. And I picked this slide just to show you that as an example of what's happening is that here are the control animals, and I believe this is sheep rather than rabbits. Yeah, it's sheep. And you see the levels of the pro-inflammatory cytokines, which we know are dangerous for the lung. And if you use no PEEP, you get a significantly higher level of these cytokines than you would otherwise get. And if you increase the PEEP, you get a slightly better situation. And this is work from San Antonio, and it's fairly old by now, but they were able to show that any ventilation, even if you give surfactant, results in subclinical lung disease. And what you get is that you get a simplification of the alveolar structure with less surface area for gas exchange, and you get less vascular capillary bed. And this is the sequence here. So what you're ending with is something that people have been calling the new BPD now, which is an oversimplification of the lung structure, an arrest of lung development, basically. And this happens with any kind of mechanical ventilation. And then you have the clinical situation as well. And there are lots of studies that have looked at this, is that when you eliminate everything else, the most significant factor for the development of chronic lung disease, or BPD, is simply the initiation of mechanical ventilation. So if we can avoid that, that is a good thing. So how can we help the baby? We can try to use CPAP to keep the lung open and help the baby breathe. And the simplest way of explaining CPAP is that it is a system that applies a constant continuous pressure in the airway, and it's important both during inspiration and expiration in a spontaneously breathing subject. And it's exemplified by this picture here, where you have sort of applied pressure here, and what you do is you open up the lung and you're breathing here, and this is the normal FRC. And the normal FRC, which is the functional residual capacity, is about 40% of the total lung volume, which means is that it's the amount of air that's left in the lung after you've breathed out normally, basically. So this is what you want to achieve, because here a small pressure change will result in a large breath, basically. So the effects of CPAP are mainly that it will increase the functional residual capacity, open up the lung, which will increase the surface area, and this will reduce the intrapulmonary shunt, and this will prevent atelectasis. We know that it conserves surfactant, and it, of course, improves the compliance. And what it also does is that it improves the clearance of fluid from the lung and the redistribution of fluid. And it will significantly reduce the work of breathing. So all of these are good effects. The optimal pressure for CPAP is not really known. I just picked some of the definitions that are flying around. And it's basically related to the oxygen delivery problem. And some people say that it's the level of pressure that gives you the best oxygenation and highest compliance, or a reduction of the cardiac output, reduction of shunt to 15% of the cardiac output. And if you put on too much pressure, what will happen? Well, you will increase the airway and the lung resistance, and you can impede venous return and reduce cardiac output, of course. And you can also increase dead space ventilation, and in the end, maybe cause barotrauma. Because if you're over-distending, you're working here, and there's not, these are bad breaths, basically, and the lung is severely over-distended. And this is the vascular resistance here. It's a U-shaped curve, and here is the FRC, which gives you the best pulmonary blood flow. So if you over-distend, you end up being somewhere here and increase the pulmonary vascular resistance significantly. So how do we administer CPAP then? And that's a very interesting question, I think, because traditionally it's a circuit with humidified, heated air against a pressure resistance, which basically, inflates the lung. And it's classic to say that the flow needs to be about 2 to 3 times the minute volume to avoid the rebreathing. And this is the basic, old water seal CPAP system, which is very simple. And basically all you need is water tubing and a gas flow. And then I put in some pictures of other systems through time. And this is the Gregory box from 1971. This was developed by Siemens in the 80s. It's a head box, basically, and was marketed. And this is the Swedish invention, which is now called the infant flow. We call it the Östersunds CPAP in Sweden. And that's a jet system, basically, and there are other variants of this. And the nasal attachment is, of course, very important because the resistance in the nasal attachment, whether it be prongs or anything, or tube or anything, is very important. You see, this is the resistance here, and this is the pressure. And these are tubes, these are tracheal tubes, and you see there's a lot of resistance here. And as you go down, here's the Argyle, which many people use, and here is the Hudson prong, and here are the infant flow devices. So resistance is obviously very important relating to the device that you are using. So if you use a bad attachment with high resistance, you'll get very bad results. And this illustrates, this is an 800-gram baby here, which is 5-week-old, he's a boy, and he's breathing spontaneously, and these are the breaths. And in the top panel, you see the pressure variations during spontaneous breathing, and there's no CPAP applied. And he's breathing with about 2 centimeters of PEEP, or 2 centimeters of CPAP. And then you put an Argyle nasal prong without CPAP on the nose, and you see what happens. There's large variations here, and at times it's negative as well. And this will increase the work of breathing tremendously. And then you put CPAP on it, and it gets even worse. And then you use a device that can do it properly, and then you have true CPAP. You have a positive pressure here throughout the cycle, and here are the breaths. And there's always, and this baby would be breathing at around a normal FRC. We looked at this recently here, and you can look at its EPUB ahead of print now in pediatric critical care. And we looked at the 7 most common systems on the market now in relation to pressure stability and work of breathing. And this panel, it's a little bit complicated, but you see we checked each system on 3 levels of pressure, basically. And this is the peak pressure, mean pressure, and lowest pressure. And you see there is a variation from system to system, and within each system, as you increase the pressure, some of the systems become increasingly pressure unstable. And we translate this into work of breathing. It looks like this. And this is the work of breathing in millijoules here, and these are the different systems. And you see there's a tremendous variation in the performance as regards the work of breathing. And some systems are very bad. These are more homogeneous in performance as far as work of breathing is concerned. Here's the classic bubble system, and here's the infant flow, which are 2 of the main systems that are being used now. And the interesting thing here is that they perform similarly, but the difference in cost, if you want to buy a system like this, is about 100-fold. So the problem is that many of these systems, even if they are very good, like the infant flow system, it has become prohibitively expensive, in my opinion. And you could get very similar results with the bubble system. And that's what has happened, and there are so many actors on the market now with these systems that the price is a big problem, I think, because the principle and the way CPAP should work is really, really simple. So you can read more about this if you want to go online. So how do we select the patients? Well, if we go back to what I said earlier, the main function with CPAP is that it increases the lung volume. And then we have diseases which are related to prematurity. A lot of the preterm babies today have received steroids. The mother has received steroids, so they have minimal lung disease, basically. But they have very soft rib cages, so they are often helped with CPAP. And then we have the classic respiratory distress syndrome, of course, which is mainly parenchymal disease, which is low lung volume due to that. And then we have cases where the lung volume is maybe normal or slightly increased, and that's the babies that have problems with lung liquid clearance after birth. and probably CPAP has a place there as well. And the interesting thing is that many people have said through the years that you need to intubate these babies because they can't breathe. And this basically tells you that most babies breathe after birth. And this is tiny babies, basically, less than 26 weeks. Almost 60% of them cry after birth, and 70% are breathing. And it's even more for the slightly babies over 26 weeks. So this is, most babies, breathe. So if you have a strategy like we have, that everyone who breathes after he is born gets to try CPAP, most babies will get CPAP. And if I go from that to the trends, what has happened with CPAP use in the last decades, basically. So this, I'll tell you a story about, it's related to our chairman as well. So this was the situation in the early 90s, and this is data from the Vermont Oxford network in 91. And it shows you that the almost over 80% of the babies less than 1,500 grams got intubated straight away. And if we look back 4 years, we have this study here that Mary Ellen Avery was responsible for, basically, is that they compared 8 centers in the US as regards the pulmonary results. BPD at that time was 28 days with oxygen. And there's one center here that stood out, and most of you know this, is that this was the Columbia babies in New York. And they used the CPAP, early nasal CPAP, as a strategy. That was their main strategy. And in Scandinavia, we had been using CPAP all along since the 70s. And Hugo got interested in, what's happening in can we compare what's happening in Stockholm? And then we did this study, and nowadays I call it the Stockholm syndrome. And we looked at about 700 babies in Stockholm County. How are they doing? How are we using CPAP? And the whites are babies who are just treated with CPAP, and from less than 1,500 grams, 31 weeks. And the blue ones are babies who need mechanical ventilation. And it's only about 50% of the babies, they go on CPAP straight away. And most of them do well. It's the tiny babies that often need intubation. So, and I remember a trip we made to Seattle for the American Pediatric Society's meeting in the mid-90s, and we stopped by in Toronto and showed this, and people were really surprised that, no, this can't be true. Well, we said we're basically just using what Columbia is saying that we should use for the babies. And these are some of the comments we got, that it only works for Vikings, but it's an American invention. Our patients are sicker than yours. It's a genetic predisposition that makes the babies tolerate CPAP. And there's a doctor who lives in the unit, basically. That was related to Columbia. And I used Leif Eriksson here as the example, since I'm always fighting with the Norwegians whether he's Icelandic or Norwegian. I say he's Icelandic, they say he's Norwegian. And he found Wineland that he called America. And after that, there were a lot of observational studies that came, and this is just part of the list. And it stretches from the mid-90s up until now, basically. And there was always, we didn't have the randomized controlled studies to prove the concept that it was okay to do this. So we've looked at this self, and I chose to show you that. And there was no one in Stockholm that wanted to do and take part in the randomized controlled studies. They thought it would be cruel to the babies to do it. So we looked at it in other ways, more observational. And for the tiny babies, we decided to do a comparison again. It's been done between New York and Boston a few times. So we did it between Stockholm and Boston, Beth Israel in Boston, which is similar. And then we also looked at the bigger babies, especially the babies who needed mechanical ventilation. And what we find here is that the site 1 is the American site and site 2 is Stockholm. We see that only about 44% of the babies in Stockholm, the tiny babies, less than a kilo, are intubated, whereas 100% are intubated in Boston. And 20% here of the babies that that we don't intubate never get intubated in Stockholm. And you have to remember that these are tiny babies. And subsequently, we use less surfactant as well. And what happens is that when the babies are 40 weeks, and this is these are the stages for BPD, and grade 1 is a baby who has been on oxygen at 28 days, but is off oxygen at 36 weeks, which is mild BPD, and that's more in Stockholm. And we have less moderate BPD as well. The slight increase here, which is not significant for severe BPD, is babies in Stockholm that are on CPAP and air at 36 weeks. And by the NIH definition, they would be classified as severe. So these, we translate this into better pulmonary morbidity using the early nasal CPAP technique. And then we looked at the bigger babies, and we did our own sort of INSURE study in Stockholm based on the Danish experience from Henrik Werder's group. And basically what we do with the bigger babies is that we let them develop RDS while on CPAP, and then we intubate, give surfactant, and extubate to CPAP again. And what we were able to do in this study was that we were able to reduce the number of babies that needed to be transferred from the level 2 center to the tertiary care center for mechanical ventilation, very significantly. And others have done this. It's lots of other studies now that have shown the same thing. So INSURE seems to be here to stay. And then we have, again, and this is done in 2000, the comparison between Boston and Columbia again, and Linda Farter did this, and that's very significant again. And this is in the year 2000. More CPAP in New York, less BPD and less surfactant use. And now we get to the randomized studies. Colin Morley did this study, the COIN study, which is published in 2008. Tiny babies, 25 to 27 weeks. And they were randomized at 5 minutes of age to nasal CPAP or intubation. And the primary endpoint was to reduce the rate of BPD or death. And the results were significantly in favor of CPAP at 28 days, but the significance disappears at 30 weeks, which is slightly odd. Something happens between 28 days and 36 weeks. And then we have the support study that was published last year. And lots of babies, 1,300 babies, high use of antenatal steroids, and the question there was intubation in the delivery room, surfactant within the hour, or CPAP, and later treatment if the FiO2 was more than 0.5. And the primary outcomes were death or BPD, and there were no significant differences there. But the secondary outcomes showed that the CPAP group had less intubation, fewer days on ventilation, less postnatal steroids, and more likely to be off the ventilator on day 7, a little bit similar to the Boston-Stockholm comparison. So what we can say now in 2011 is that all of this put together suggests that it's entirely possible to start with CPAP in even tiny babies and treat them with surfactant only if they require ventilation. And I took this picture. This is one of Hugo's pictures, which shows the lung fluid resorption after vaginal delivery versus C-section. And just to show you that for vaginal delivery, and this is related to catecholamines, but if you focus, here's birth and here's 2 hours, is that the compliance is much higher here. And in cesarean, the lung is filled with fluid and you have a very low compliance. And we know from other studies now that the transpulmonary pressure is very important for the lung liquid clearance after birth, and that's studies from Tepas and others. So it's entirely possible to assist the lung liquid clearance with using CPAP. There's not much randomized material out there to support this, though. There was this study here from Australia, Buckmaster, in 2007, which randomized 300 infants with respiratory distress, and the babies were more than 30 weeks gestation. And the traditional treatment is a baby, moderately big baby, is hood oxygen or oxygen via nasal prongs, is to use CPAP instead. And they saw a very significant decrease in the need for up transfer to a tertiary care center, so the babies were able to stay in their home unit. There was a slight but not significant increase in pneumothorax in the babies on CPAP. And this was recently followed up in Australia. And what's happened with the CPAP treatment. And you see what has happened here is since 2007, the mechanical ventilation has maybe decreased slightly, but the CPAP use has increased a lot. And you can see it here as well, that there's a huge jump here after the publication of the Buckmaster trial in Australia. So most of these babies are being put on CPAP, and that's a mixture of diseases, basically. It's, poor compliance due to rib cage problems, it's maybe some RDS, and there's a lot of lung fluid resorption problems, wet lung type of things. So my conclusion for this is that CPAP and INSURE are accepted methods worldwide to deliver respiratory support to newborn preterm infants, and it's here to stay. And just to finish off here, I'll show you three pictures basically. CPAP is very important for the bonding between the mother and the baby and the parents. And it's simple, and it's all dependent that the nose should be open. And these are just simple rules that we use in Stockholm to make sure that the nose is patent, basically, and we're able to deliver CPAP. And CPAP makes it easier to care for the baby, because these are vulnerable patients, and they need long periods of continuous sleep and rest. And CPAP assists in the skin-to-skin contact and the child-parent bonding, which Niels will talk lots more about. Thank you very much.